Welcome to our session. We are so excited. There are so many people here to learn about social prescribing. We have a wonderful panel today, and I will go ahead and just give a brief overview of our agenda. We do want this to be, a discussion, so there'll be a few slides here and there, but generally we're going to talk about, I'll introduce our lovely panel. We will talk about what is social prescribing. For folks who are not familiar with the concept or maybe heard of it but aren't sure what it actually means and looks like in practice. We will talk about arts-based social prescribing, specifically with art pharmacy, and some of the efforts that are happening locally here in Atlanta as well as across the country. We have an audience activity, so get your pens and paper or your notes app ready for that. And then we'll talk about future directions and have opportunity for question and answer at the end. So without further ado, here is our lovely panel sitting in front of you. My name is Lucy Bailey. I lead research and evaluation at Art Pharmacy, an arts-based social prescribing service that works with many of the folks who are represented on this panel. First on our panel, we have Dr. Alan Siegel, who's the executive director and co-founder of Social Prescribing USA. He's a family medicine doctor at Kaiser Permanente, and he went to Emory School of Medicine and did his residency at Grady right down the street. So got a bit of a local presence here as well. Social Prescribing USA is the principal advocacy organization for advancing awareness and implementation of social prescribing initiatives here in the United States. We also have Dr. Carla Perissinotto on the other end of our panel here. She is a professor of geriatrics at UCSF. She has been studying and publishing loneliness among older adults and advocates for education and systems change to better support social connection interventions. She's also on the Scientific Leadership Council for the Foundation for Social Connection. We have Dr. Emily Pinto Taylor here as well, who is an assistant professor and geriatrician at Emory University School of Medicine and Grady Hospital. She researches a wide variety of social influences on health among her patients and is a art pharmacy prescribing partner, actually implementing arts-based social prescriptions with her patients in cancer and palliative care settings at Grady Hospital down the street. And then finally, we are delighted to have Christopher Moses, who is the artistic director of the Alliance Theater, about a mile and a half up the street at the Woodruff Art Center. He has 20 years of leadership experience in professional theater and arts-based community engagement and supports a ton of programming related to using the arts and theater specifically to support health and well-being at the community and population level. Can you hear me without the mic if I just talk really loud?
The mic's better.
Okay, I'll keep it. Okay, so to start, I did just want to advance my slide. All right, we're going to start with what is social prescribing. So I will pass it over to no one more qualified to talk about this than Dr. Alan Siegel. Dr. Siegel, can you tell us a little bit about what is social prescribing?
Yes. So I would have to say that this is the first time that I've ever been in a conference or with people where I didn't have to answer what is social prescribing. So it's been really lovely to have a group who have already heard about it. But I think that a way to look at it is that the social prescribing is really actualizing everything else we're talking about here into the healthcare system. So basically taking all this social connection stuff and then figuring out a way to build it in. So that's really what it is. And in about 32 countries now. Some countries are widespread, like the UK, Canada, Australia. We tend to think about it as several different ways to refer people: arts, nature, social connection, movement, and then volunteerism is sort of the 5 primary. But around the world, a lot of it is around social determinants. Sorry. Better? Okay.
And
All right.
hold it like that, like this. Yeah.
Yes. All right. Sorry about that. So better? Okay. Around the world, a lot of it really is about social determinants and housing and helping people with computers and all that kind of stuff. So it's in this country, we have a whole social determinants movements. And so we are really concentrating mostly on arts and nature and social connection as kind of our primary places to start, and really concentrating on building it into healthcare referral from health professionals. But at some level, we support social prescribing eventually being something that everybody does and doesn't need to do it through the healthcare system. But starting in the US, it seems like a good place to do this is to, you know, start off by building it in. Um, yeah. And then really what it concentrates on is really connecting people to community. So I think when we do this well, we will have a more connected community. So we look forward to seeing it grow and become more widespread.
Awesome. And then to anyone on the panel, if you want to think about or speak to how it is being used in clinical settings today, right? What kinds of settings or populations for whom do you see this being used today in the U.S.?
I can speak a little bit to that.
Sorry, we got a panic. It's for the video, unfortunately. I'm just gonna play hot potato with the mic. It's all right.
Okay. So I would say that it really depends. It also depends on what we mean by social prescribing. Even though Alan gave that formal definition, what we may do in practice is very different. So if I tell my thank you.
Yeah. We're next up. Let's hear your motives. Yes, a light bulb went off. Yeah.
So if we think about without a floral component, I've probably been socially prescribing my entire career, just didn't call it that, right? If I fooled my 40-year-old patient to call their mother, if I fooled my 82-year-old patient who just moved to a new community to buying a new chess club, that is in a sense social prescribing, but it's not a formal way of social prescribing. So when we think about how we're doing that, there's a lot of variability. And that's probably where the field needs to move and where we're trying to evaluate and put some structure around, which I can talk about. In terms of populations, in terms of where we're studying more, where things are done more, you're thinking about the highest need, highest risk populations. It also depends on what that is. For me, I'm a geriatrician and palliative medicine physician. So I'm going to focus on my older adults who are most disconnected or my older adults with serious illness. I'm not looking at pediatrics. And that's probably where most of the evidence is. So if you think about social determinants being the driver, we're going to focus where the biggest gaps are. Pass it down and start frying.
Yeah, and just it's happening in a wide variety of environments around the country. So if people are interested in learning more about it, there was an article that came out earlier this year. I was super psyched that it came out, but it was basically 23 different case studies of all different sorts of how social prescribing is done in this country. A lot of it was arts-based. Their arts, nature, what really kind of dominated that, but there were zoo programs, there was summer camps. So there's a lot of different ways that it's happening. And a couple examples I'll just give. One that I really admire is a group called Open Source Wellness. It's actually based out of Oakland, where I am. But they create groups that are health coach based. And I'm a big fan of groups in general. I've been doing medical group visits for over 10 years. I just think when you get groups together, I don't have to tell this group, but just magical stuff happens. But I think that is a form of social prescribing, is doing medical group visits. But they create groups either in clinics or in the community. They're health coach based. They do mindfulness. They do movement. They're now spreading out to YMCAs across the country, and they're a wonderful example of what they call community as medicine. There's health insurance based ones. The Horizon Blue Cross Blue Shield was the first one that connected with the New Jersey Performing Arts Center, and they took their most vulnerable patients, their highest utilizers, and they were able to put them into programs and have had a lot of success. So there's all kinds of examples around the country that are worth working, as far as we'll learn more about Art Pharmacy, who are doing stuff all over the country as well.
Thank you. Thank you both. You talked about both of you talked about like this idea of there being really high need groups. I think words that we've heard a lot this week are social isolation and loneliness, and how social connection can help fill that gap. What are some of the outcomes that are associated with social prescribing, right? What do we hope to see when, we give a patient a social prescription? And what is the kind of broader evidence base say about what we can expect from social prescriptions when it comes to these really important high need groups?
So we are still early in the US. We have groups like Art Pharmacy who are creating great preliminary data. There is great data from other countries where they have return on investment of anywhere from $3 to $7 between UK, Canada, and Australia all have that. We definitely, desperately need that data to be able to go to health insurers and say this is not just the right thing to do, it's actually financially viable and, you know, worthwhile to do. So we're early in the evidence. So we have the preliminary stuff that from, I don't know, every program that I've seen, the preliminary data is amazing. But we need some of that hard data. But yeah, I would say abroad, there's all kinds of data. They have data 25% decrease utilization for the hospital, for the ER, for clinics. That kind of data would be amazing to have in this country because, you save money. And so we are people are working on it. And in the next couple of years, we'll have that data.
Can I add to that? So if I can add, as with all things, data and measurement depends on what the question is and what you want the outcomes to be. So for my individual patient, the outcome may be their well-being and how connected they feel. But if it's a health system or a payer, what they're interested in may be very different than what the patient themselves wants. And so it really depends. But you're right, Alan, most of what people want is utilization and overall cost of care. As we think about, depending on what population, if you think about if Medicare exists in 2030, it's also supposed to be value-based. Very funny, not funny. It's also supposed to be value-based, which means we're really looking at the overall cost. And so that's where we can see a path to sustainability of some of this if we continue to prioritize. So the other thing I would say is when we think about the evidence base is what is the evidence we're looking at and asking about? Because we have evidence for community-based organizations and for things that are tackling social problems. Is that social prescribing? Is social prescribing the process or is it the intervention? And so there's a little bit of gap, then not a little gap, there's a big gap in the literature in terms of here's the problem, here's the solution. Is it like the other models in the rest of the world that had a link worker that we're studying, or is it the actual intervention? And that's some of the things that we need to still unpack a little bit.
Yeah, just to piggyback on that, I mean, the evidence, all the interventions have huge amounts of evidence behind them. And I don't think that we have to reinvent that. So take the arts, for example. There's like 30 or 40 years of evidence with this being done in hearts in healthcare systems. And part of my motivation has been that has remained a niche. And I think social prescribing is a vehicle that could then make it available for everybody, as opposed to being kind of a small group of people. There we go. Look at that. And
That doesn't need to.
but the evidence for the nature, evidence for social connection, those things are established. And so I don't think that we have to reinvent all that stuff. I think we have to see it in as the vehicle built into healthcare, and how does that work, and is it worthwhile for systems like that to pay for the interventions, to pay for the link worker and all that stuff.
Can I make a quick comment, Dr. Siegel?
Yep, please.
The other thing I was gonna, we have more microphones. One of the other comments I was gonna make. I love that point about, are we studying is it the process or is it the end result that social prescribing is? I think it was early on in working with Lucy that I came to realize that I think another kind of frame shift for me is that me, as somebody who works at Grady exclusively with people who are uninsured and underinsured, my sort of happy space that I'm familiar with is working with nonprofits and in the nonprofit sector. But the reality is, if this had data behind it for people to care about it, it had to actually be cost saving. And we have to talk about that. And the for-profit people have to want that because they will see better profits, which we happen to know is associated with better outcomes. Right. And so I think that has been a frame shift for me in sort of seeing what it looks like clinically, because that isn't typically something that drives me. But the nonprofit space is only so big. Right. It can only cover so much % of what we do.
Great. This feels like a good time to tell you guys more about Art Pharmacy. So I'm going to do that really briefly, and then we'll get into the discussion more. So like Dr. Siegel mentioned, arts-based social prescribing is a really common form of this model. And that is what Art Pharmacy has. So we work with partners in healthcare, education, workforce, and more to address the mental health and social isolation loneliness crisis at the same time, right? addressing people's behavioral health needs while making them feel more socially connected. And our model is based off of that evidence that we were talking about, right? There are centers for arts and health, centers for arts and medicine that have been doing this research on how the art helps people heal for many, many years, decades. So we see that as the treatment, right? That's what people are getting when they get that social prescription. And the social prescribing is the delivery method, right? It's how they get there. And what's really important about social prescribing is that connection to health, right? Whether that's your healthcare provider, your clinician telling you in an encounter, it's really important for you to do this for your health, or you're a college student and you're going to your RA and they see that you're struggling and they say, this isn't a resource for you to help with your mental health. So that social prescription really increases the salience and the importance of engaging in the arts for your health and well-being and for social connection. There's a few key studies on here that really highlight the evidence base. And what we do see is that arts on prescription programs do have the potential to reduce things like depression and anxiety, especially among folks with complex healthcare needs or multi-comorbidities. And that arts engagement in general is very connective and very healing for people. And so we work with across the spectrum of health plans, healthcare providers, health systems, as well as universities and colleges. We are in 9 states. We are in Georgia, California, Massachusetts, Connecticut, New York, New Hampshire, Wisconsin, and did I already say North Carolina? Nope, North Carolina. And so what we really do is try to bring this model and implement it with our partners so it can scale, right? So it can reach as many people as possible and be able to solve this social connection crisis or social isolation crisis by connecting people to things that already exist in their community, right? We're not creating new programming. We are bridging them into the healthcare setting and using that power of the prescription pad to make sure people can engage. We also always work with third-party payers, like these partners, to cover the cost of access because we know financial barriers can be a huge deterrent for people to engage in these things, right? And so we want to reduce those barriers and make sure people can actually get into these activities and that they feel supported in participating by arranging transportation or making sure that their mobility and accessibility needs are addressed. This is how our social prescription model works. It's very similar to like your traditional link worker model in the UK or the US or Canada, whereas they have public national health systems. We have folks who are dedicated care navigators at Art Pharmacy who do that barrier assessment, help people identify what it is that they want to do and get them into those activities. Also provide some like motivational interviewing and health coaching, right? If you think about folks who are extremely socially isolated or lonely, they may not feel comfortable going into a community space. So we work with them to really make a plan, help address those fears and anxieties, and get them participating in something once a month for 12 months, their intervention being like a year-long prescription. And so the way that we find people's match is through technology, and that is also how we're able to scale. We have thousands of community partners all over the country. We have all of their activities and engagements in our system tagged to different health benefits or characteristics of the participants. And so we use the sort of community engagement vetting that we do and that tagging. We use all that information on the member's profile that they can set up with Art Pharmacy that tells us, what do you want to work on? What are you interested in terms of arts and culture and nature? And what does your mental health look like, right? They do these intake baseline assessments using validated mental health and loneliness measures. And then we also look at the peer-reviewed evidence, right? Like, what does the science say about what is going to work for this kind of person with this kind of problem? And so far, we've seen really incredible outcomes. I have been evaluating like healthcare programs for over a decade, and it's very rare to see such incredible progress for people in a short intervention like this, where they're participating once a month for a year. It is not an everyday thing. It is not an intensive. It is a habit-forming health behavior change intervention, essentially, to get them to engage in their community and in the arts for their well-being. And so we see 79% of our members who come to us with a low mental health score improve that score, as according to the WHO 5 well-being index. We see 62% of members who come to us with some indication of loneliness have a reduction in that loneliness score. And then about 60% who come with a positive screening for screening for depression or anxiety do reduce those symptoms using the abbreviated behavioral health measures. Um, we also see that we're having an impact on that relationship with the provider, right? There's 94% of the members say that they trust their provider more, would recommend their provider more because of that art pharmacy social prescription. So not only is it a connection to community, it's really enhancing that relationship with the provider in the room because they're able to ask not what's wrong with you, but what matters to you, right? What do you want to do as part of your health, and how can we open the door to do that? Um, just kind of a couple points on our model. So, one thing I want to zero in on here is just that it's stigma free, right? That therapy and medication and our traditional behavioral health services are very important for people, right? We're not trying to replace anything that people need. However, there is a ton of healing that happens in community that should be incorporated and thought of in our system, and that may be more appropriate for folks who don't feel comfortable in certain spaces or don't feel comfortable yet. So yes, we have a national network of arts and culture partners. We're growing every day. We're really excited to be able to have the opportunity to work with national and local partners like we have on this panel to be able to deliver the model and build the technology to help us scale so we can reach everybody who needs it. And when we just think a little bit about what art pharmacy does and what kinds of activities people are doing, this is how we have defined it and expanded it to really meet a wide variety of your arts genres, your settings, your types of engagements, and your participation modes to really enable people to find exactly what is right for them at the moment that they need it. Okay. That was a lot of me talking. Now I'm going to turn it over to other people who can talk about specifically Chris. I wanted to ask you, um, being the kind of leader of an arts organization, what do you see are the healing impacts of the arts or the healing effects that the arts can have on folks?
Wow, wow. Thank you. I am so fortunate. I get to see the impact every single day. And it's across demographics. I'll start by talking about because I was thinking about it on the way here. At the Alliance Theater, we do a host of classes in addition to all the professional work that we put on stages for every age group. We also offer classes in acting for every conceivable age group, truly from 0 to 100. We have classes for babies and parents too. It's really special. But I was thinking about the first person I met who came through art pharmacy was this woman, Lynn, who was very isolated, an older woman. And she found out about the Alliance through the social prescription and came to take an acting class years ago. Not innately gifted or talented, she had harbored, I think, some dreams of being an actor at some point. But what she found there was intense and profound community and came back week after week, took class after class. And it was there that she found meaning and started going to the theater with these friends, started going to dinner with these friends. It brought her out of that isolation. So I saw it play out in real time with one of the first students that ever came through that program. And I know we'll talk a lot about the aging population, but it's really interesting to see the arts interventions have impact at every stage of development. I think a lot about the work we do for new parents. We have programs for parents and babies. We do weekly free programming that involves either learning how to make a story interactive together, but the whole point is doing something together, or writing and creating a tailor-made lullaby together with a theatrical composer in the room. And these experiences, what they do for parents, particularly battling any kind of postpartum depression, to have this place where they can create something together and have lasting memories is life-changing. And we see it time and time and time again. I don't want to put you on the spot, but do you want to share like even your own child kind of do a summer camp? You can see these effects.
Are any of y'all from Atlanta? Are any of you guys Atlanta people? Okay. So any Atlanta parents know that, like, really any parents anywhere, know that summer, turns out after your kids leave daycare, summer is extremely hard. So I'm going to watch them. And Atlanta parents know that the rat race to get kids in summer camp is extremely difficult here. And it starts in like January. And so for years, I've been sending my kids for a few weeks in the summer to Alliance Theater Camp, which I always thought was like a lovely idea. And I have like a time saved to log in and get the spot because it's like one day. But I have 3 kids, and one of them has ADHD, and he's not an easy child to have in camp. I know that he's a high energy kid. He's big body play all the time. And, one of the things I just love about sending him to Alliance Cedar Camp, and the first time we sent them, I was very unsure of how that would go. And, I was sharing that afterward, like all I ever received every single day was so much positive affirmation about like how fun it was to have him in class today. And on the last day of this past year, on the last day, you come and there's a performance for your families. And he was in a class where his 3 teachers were Black men. My son, who is biracial, is in a class with these 3 Black men who are looking at him and are like, "You are so great at this. Like, do that dance in front of everybody as part of the performance." And just what it was like to watch him be validated in spaces where otherwise he shows up, and what do? They look at him and they're like, "That little brown kid who's too active," right? And instead, he shows up to this space and they're like, "You belong here." And they connect him with that community. And he walks away and he's like, "I got 6 kids' phone numbers and these are their moms." And it just building that space of connection, and I think identity was huge for us. So I shared that before, that just personally I find it so meaningful.
Did you?
Um, yeah, I mean, that story basically that you're telling is just the same experience that I keep hearing from others. I mean, uh, I don't have my own social prescribing program going yet, but so I will tell you those stories soon. But certainly a place like Open Source Wellness, the story of someone coming in and taking the classes, then the classes end and they want to keep going, and so they kind of keep volunteering, and then they become a health coach themselves and become, and just that becoming part of people's identity is just such a critical part of this work. And
Oh, it just I forgot a great part of the end of that story with Lynn, who was taking these classes and taking these classes through Art Pharmacy. Once the social prescription ran out, the medical company was no longer funding. The students like raised money to support her because they saw how meaningful it was to her, and I think it just kept reinforcing that this was truly profound community that she had found through that program.
Yeah.
And you raise an interest, a really important point with that is that we often think about these interventions and programs as being all positive. And there are some risks, especially, and that's one of the complications like we're dealing with here in the US when we don't have a single payer or insurance plans and what they have to choose yearly. There's some great things to be able to say, oh, this is paid for by X insurance, but when their benefits change, you could lose benefits. And so how do we, as we've been talking at this conference, build this all into this is standard of care. This is not an add-on. This is a basic benefit. How do we get it into the basic benefit of Medicare and Medicaid and not an add-on so that your patient, your family member, yourself doesn't lose that? And how do we also, and I can talk about this more, how do we think about social prescribing not always as a go to somewhere and to some organization, but that it's really tailored and individualized to someone so that if my social prescription is I need to get back and do my mosaics that I love to do, like maybe that's what I need to do and I don't need to go somewhere to do that.
That's a great point. That's great. And I to follow that thread, and I think especially with talking about payers, some of the most high need or high impact populations are these older adults, as well as like youth, behavioral health, young adults struggling with loneliness, social isolation, depression, anxiety. And I wonder kind of, I know Dr. Pinto Taylor, you and I have talked a lot about kind of how you identify patients in clinic or in the setting who might be a good fit for something like this, right? Outside of just the demographics, like what are the things that we start to see as, oh, this person is ready for the social prescription or could benefit from the social prescription?
Yeah, I think that's a great question, because there's a piece of me, of course, that feels like everybody can benefit from this. I think most of us are like, I want to go to that receptive us. So my clinical practice, outpatient, is in palliative care at Grady. So I see only people with serious illness who generally are having life-limiting illness, and I work at Grady. And so, I frequently talk with patients about how I truly foundationally believe that the richest people have people, and people who have people are okay. And people who don't have people fall apart. So what does it look like to help people connect with people? In palliative care, there is a like very fundamental concept of total pain, which is that people, they're used to reporting their pain to the nurse on a scale of 0 to 10. But pain is not just physical, it's physical, emotional, social, spiritual. It is all these things put together. And so, one of the examples that comes up for me, which is not a high risk person, is a young woman in her 30s who has incredibly bad pain related to a cancer. But after multiple visits with her, it sort of came out that her fundamental issue is not her cancer. It's the fact that her cancer is in her uterus and she needs her uterus out. And all she's ever wanted is to be a mother. And then the next visit, also, she herself was adopted, was mistreated, was not loved, and deeply believes that she's have a biological child. And like all of this, like, is not fixed with oxycodone, right? Like morphine doesn't fix that. And so kind of thinking about when you meet people and you're talking with them about what their distress is, I think so much of it is just being open to like, what does suffering look like for you? And just being open to people suffer in a lot of different ways. I think something that hasn't come up, but I think is really relevant in Georgia is we have an incredibly spiritual population in Georgia, right? It's a very religious state. A lot of my patients find social connection in their faith, and that can often encouraging connection in those spaces is another place where I feel like I do a lot of social prescribing. Can't tell you how many people I have on like church lady phone trees. Or who have told me they can't leave their house, but all they want to do is pray for people. And it's like, great. Seems like you could minister to the shut-ins, like you could run the church lady phone tree. And so I think being willing to be open to what does your suffering look like and all these different dimensions of suffering is probably part of how I identify that. I'm sure you have other thoughts about that.
Yeah, but actually, what you said is this would be great for everyone, and I think that's true. And again, if we get back to this idea of this is the seeds of connection, this is the basic fundamental human need is to feel connected. There is a role for us talking about social connection in every encounter. And my colleague Julianne and I wrote a paper looking at what does that framework look like in healthcare, which is really the basis for social prescribing, which is educating about social connection is important to your health. Loneliness and isolation is harmful. How do we assess for that? That gets to measurement. And then how to respond gets at the social prescription. But this is a process. Because what works for this woman to go to theater may not work for my mom,
Right.
and may not work for the other person that can't get out of the house. And so we need to tailor. And that's also something that my colleague in Sierra Brim, Dr. Ashman Cotwell, also a geriatrician, palliative care physician. You may not ever see 3 in the same room again once you're out of jail. Pretty like Tavis is around, so what? There's another one around here. But we are studying this process because what we're learning is that, again, we know communities know what they need to do. Physicians and other healthcare providers know that there's something wrong but we're not doing a good job. And how do we do that male part? And how do we do something that's sustainable, works, and is individualized and cost saving and everything? So.
Yeah, I mean, I would say that it's not that hard to find patients. That I'm in primary care, and it really is a daily thing that I see people come in who are depressed. I mean, it obviously depends on the questions you're asking, but people, we don't have a lot of tools. We run out very, very quickly out of therapy and medications, so thinking about other things as I'm trying to bring that more into my regular clinic visit. It's a natural thing that is all the time. And so I think it's not hard to find patients there. I think then if you look at the literature, it's chronic disease. It's certainly for loneliness. So, I mean, I agree that eventually my hope is that we get to a place where this is available for everybody and it's also, the other big thing is that this is change. This is a system change. Try to change doctors. They are probably the hardest population of people to change the way that they do things. How people learn to do it in residency is sort of like this godlike thing. And so try to get someone to think about the arts as an equal intervention or maybe even a better intervention than the things that they're doing. It's going to be a process, and it's going to take a lot of back pressure to be able to get people to think differently about using nature, about using the arts, about really these other things that are interventions beyond what we do every day.
Yeah, great points. Thank you all. On this topic of both social prescribing is for everyone and that it is highly personal, right? That there isn't a one size fits all and sending everybody to the same place is not going to be effective. I want to do a little activity with you guys um, so that we can kind of share our thoughts on what's your social prescription, right? Thinking from what you've heard so far, from the examples you've heard and how it works in clinic and outside. Take a couple minutes and kind of go through this process, right? What's one health or social connection goal that you really want to work on or want to achieve? I think we're all in this room probably hyper aware of the social connectedness of our lives or lack thereof. And so hopefully it's not too much of a stretch, but kind of think about what is the thing that you want to do. Then kind of write down or brainstorm activities, things that matter to you, that bring you joy, or something new that you want to try, right? Because that is also where connection and growth comes from, is getting outside of your comfort zone and learning something new. How often you might want to do this activity. Importantly, any barriers that you might face, right? What gets in the way? What is the thing that stops you from doing that? And either at all or as often as you'd like. And then kind of culminating in this simple one sentence action plan for what you're going to do. And in the sort of common understanding of social prescribing framework that was published by Mull and a bunch of other international social prescribing researchers, this idea of the action plan is really important, right? You're documenting what it is that you want. And that's also, I think, very important for how we think about healthcare in this country, documentation and alignment with goals and metrics that matter to the healthcare system. So take a couple minutes and do this. Then when you're done, go ahead and share with the people at your table. And you get bonus points from me if you make a plan to follow up, right? If you actually take that next step of that behavioral intention, right? I'm going to do this with you or alongside you, or we are going to make a commitment to ourselves to do this. I can just share a brief personal example. So I'm 24 weeks pregnant. And when I was first finding out I was pregnant, I was feeling extremely isolated, right? Very isolating experience to feel like something's happening, but I can't share it with people. And so what I really wanted to do was connect with other pregnant people. That was my goal, was just to find some common experience. And so I love yoga, and I know prenatal yoga is supposed to be really good for you. And so I actively, through my fatigue and nausea for the first, couple of weeks, found a weekly yoga class, prenatal yoga class, committed to myself to go every Sunday and be in community with people. And it was so powerful. And I still go because I found community. It's a regular habit now. And it is a place where I feel completely healed, right? Healed from what I'm going through, or connected to other people. Some of the barriers were time, right? It's a Sunday afternoon. I just want to chill out. I'm exhausted. I don't want to go anywhere. Others were cost. But I kind of found a membership that worked for me. And also being afraid of going alone, which was a barrier at the first session and then was completely removed after that, right? Once I was in that community space, I was like, this is great. I will come back every week. So just sharing a personal example so you can see how this activity is structured. And then take 5 minutes and I'll let you know when it's time to share out or have your own discussion as you finish up your goal. Table.
So
Do you want to share what happened? Your plot was share your success story?
Okay. I confessed that when I heard this prompt, I didn't want to do it. I was happy. And I was thinking about it as everyone also kindly shared around my table. And I declared that me coming to this event was me achieving what I needed for health. So I have 4 kids. My youngest was born, he was 5 months old when the world shut down for COVID. So I had a 5-month-old, a 2-year-old, a 5-year-old, and a 7-year-old. And I took a year off because there was no way our life was going to function if I didn't. And the last few years have been a process of regaining some measure of balance or something in my world. I'm in a PhD program, but me coming here was this over the last year is the first time I had left home overnight other than to birth one of my children, which is not an exaggeration. So me getting on an airplane for 2 days to say this is what I need for my professional self and for my whole humanness. So Battle is so good. So,
Hey, yeah. Thank you so much. Anyone else want to share? Is there a refill for this?
Right, exactly.
Yes, if there's a refill.
Happy. Yeah, please just tell people what you do. It's like that with this more in context. Tell people what you do.
oh, uh, so for the last 20 years, I have been a pastor, a congregational pastor, and it is working in, I'm so grateful you talked about faith, because I think the spiritual component is huge, but not in a token way. And figuring out how that gets integrated. My experience in congregational work is that we have a lot of work to do on how to set the table for connection, that it takes more than just putting people in the same place at the same time. And we don't know how to do that very well. So I went back to school to see what the research says and see if I could be part of helping to create the evidence base for how we could better set these cables of connection.
Amazing. Thank you so much. Thanks for sharing. All right. Well, I do want to just kind of wrap up our discussion with kind of like what's next, future directions. You've heard a little bit about what's needed in the research and evidence, what's needed for larger scale adoption, and some of the challenges that might come with trying to implement this system wide. A very important issue was raised around increasing the burden on physicians or healthcare providers to do more to account for social prescription. And I just want to just make the point. This is the title of this panel is Bridging Systems, right? And so the way that we think about social prescribing is not we need to add more to people's plates to do this. It's that we need to be more effective at building those bridges. And at Art Pharmacy, that is why we exist, right? We want to make it easy for providers to be able to incorporate this and for community arts partners to continue to fill their wonderful programs that they're already providing, right? These things are happening. We just need to build stronger bridges across those sectors to make sure they can be most effective. So that's what I'm looking forward to in the future, to continue to do this work and increase access to this service. I'm curious if each of us can share what we're looking forward to in the future as it relates to social prescribing.
Well, we're at a very exciting time in social prescribing's world where it has really just exploded in the last year plus with media, with all kinds of stuff. We just had we just brought together people about 2 weeks ago to try to, about 50, 55 leaders from around the country, to try to forge how does social prescribing work together, all the different sectors in social prescribing, to really kind of move this thing forward. Arts prescribing has been moving forward. It's got a lot of momentum, but the other areas, not as much. And so we think together we can do a lot. And so that gave me just a lot of optimism to see all these people who want to work together and really move things forward. So I am very excited about where I think that's going to lead. And yeah, there's a lot to do, but it just seemed like it's on the point of exploding. And I think all of you are really just helping to make that happen by just bringing up the social connection piece. I feel like social connection is sort of the bottom for all of the social prescribing stuff that we're doing. So it's just such a critical piece. So the work happening here is really critical.
I'll answer one very hyper local to what we're doing just a mile and a half down the road at the Alliance Theater. A few years ago, we did finished a 7-year longitudinal research study on the impact that an arts and cultural field trip has on a young person's development. There was no research in the field, and we were constantly met with skeptical leaders being like, why are we going to take kids out of school? Why are we going to fund this? There's more important things to focus on. And we got the results the very same month that the Surgeon General came out with that dire warning that the mental health crisis had reached the level of an epidemic in the young people in our country. And he listed all of these contributing factors: a rise in absenteeism, rise in behavioral infractions in school, a lack of concentration, a rise in isolation, a despair roiling our kids. And the research got back hit every single one of those metrics. The kids that were coming on the field trip were leaving with the ability to tolerate multiple points of view about a subject. So we're building more tolerant human beings. They were showing less behavioral infractions. They were showing up to school at higher rates, deeper levels of concentration because something shifted in that experience of art when they were experiencing it. And the last one that I think about every day is they left with a greater sense of hope in their own future from experiencing these arts field trips. So we decided we had to act on that research, and we are literally ripping off the front of the Woodruff Arts Center building and creating a full-time youth and family theater. And the point is that this becomes a birthright. Talk about shifting the narrative. If you grow up here, you have access to these benefits, and we'll be opening that in January. So that's what I'm deeply excited about that. And that on the macro level, I'm hopeful that this moment in time that you talked about, Alan, is that the arts will also benefit, that there is a cultural mindset shift in the value of the arts. I think for so long they've been, restricted or thought about as something that's available for the rarefied few, and it's just some entertainment with no other value. And I think the more that the research is bearing out that this is a vital part of what it means to be connected and healthy, that'll have a great impact on our whole country.
Such a big story. I think I have two thoughts. I operate in two disparate places. So I work at Grady. I also do school-based health telemedicine on a Native American reservation in Montana. I've been doing that for the last 2 years. And I cannot tell you what it is like to encounter a 15-year-old who tried to jump in front of a train on telemedicine when you have nothing to offer them. You have you. And then seeing the sense of disconnection, which is even compounded by the laws on this reservation in which that person ends up actually being incarcerated in order to keep themselves safe. So seeing the experience of talking to someone in orange in a room who is 15 and you have nothing that you can offer them. And then conversely, being in a space of deep suffering here and being able to say, I have some ideas, I have some things that we can offer you. There are things in the community that are made for you. And I think I had so much gratitude specifically for the way in which Art Pharmacy has really partnered us with organizations like Lions Theater that have a deep cultural concordance with our patients. These are not things that people don't want to do, because I frequently get people who sort of look at me and are like, I don't want to take a pottery class. I'm like, this is not a pottery class. And so giving people the opportunity to participate in something, look, if you want a pottery class, I like pottery, you can do that. But if you want to do something different, if you want to take a hip hop class, if you want to go to a sip and paint thing, if you want to go to the ballet, you can do so many different kinds of things to connect you to the community. And I think seeing the difference in what it is like to be able to offer connection and what it is like to not is so stark for me. That I'm excited to see what it would look like to broaden that. And I will share very briefly from some of the data with the work that we've done at Grady with Art Pharmacy that we have seen with our patients who are, I will tell you, deeply suffering and disconnected, the kind of overall population of people that we were looking at. People who got engaged with Art Pharmacy and who connected with these social organizations, these arts and culture organizations, they were more likely to come to their appointments. They were less likely to go to the ER. They were more likely to refill their medications. They were less likely to get admitted to a psychiatric hospital. And these were significant differences. And the comparison group were also falling apart. So it wasn't that they were just doing better. It's that there's something about that connection that makes a difference. And our end might be small, but I'm hoping it will be bigger.
Man, I don't think. Oh.
I'm going to go a little bit boring. And serious also, that when I think to the future, it's hard not to ignore democracy and the threats to democracy and how we can maintain a culture of connection, whatever that looks like for all of us, and outside of this space. This is a space of like-minded people. How do we bring this energy to the outside world, to our own communities? As it relates to social prescribing, I'm kind of in two camps of, I'm hopeful to continue informal social prescribing, actually, that this becomes the fabric of our lives, a birthright that we can all do this, and at the same time, a more formalized and understood process for social prescribing, which we're studying, so that it can be systemic and also sustainable. So I'm looking at both of those things. I think with so much focus and talk of social connection and prescribing, there's a risk of cheapening it and losing value. And so we have to really maintain rigor and standardization. And that's kind of the nerd in me, but it is the part that wants this to continue so that this isn't a phase that we're through and that we fail at. So.
And that seems like a good chance to plug our study, Carla, that we are going to are embarking on with funding from the National Endowment for the Arts, Art Pharmacy.
Money came through.
To essentially evaluate art pharmacy's impact, the program evaluation of art pharmacy among older adults experiencing social isolation and loneliness, with the real attempt to try to quantify and dig in and contextualize and operationalize these models in a way that can be most effective for scale. So thank you guys. We have some time for questions, like 7 minutes, 8 minutes. Yeah, okay.
Hey, I have one comment, I guess. We have known for decades that prevention is cheaper than tertiary care, and yet we lack the will to fund it. And so it's great to have more data that proves that these interventions, but these are prevention interventions. And so I'm curious about that. And this is the last thing I was like, one thing you said, it's hard to make doctors change. So I'm a physician, a primary care physician. And I would argue that it's very easy to make doctors change if you change the study so they could do it. And I'll just a little of the anecdote. In 1945, the Dr. Lobb, the doctor in the town where my uncle lived, prescribed leaving his mother and going to live with his uncle because they had a terrible relationship. That's sort of social prescribing. And it was the norm in a time where doctors had the opportunity and the ability to create relationship with patients. So how can we go back to a system where the relationship between the doctor and the patient is prioritized over all the other crap, frankly, that we have to prioritize?
Great question.
So that'll be an hour.
Do you want to see?
Sure. I guess I'll address the first part. Yeah, I mean, I don't think we need to think about this as prevention. I mean, the data, what's our data for depression and using antidepressant? It's not great. So the data that I've seen from every study that I've seen is way better than what I see. So I do think that we need to think about this as treatment, not just as prevention. And that's where if you start getting into chronic disease and you start showing that diabetics who go out and do arts engagements have better outcomes, yeah, that's where the money is. I mean, so I do think we need to think about it as a treatment modality.
I would probably say it's really about if we think about this from a public health perspective and thinking about it, primary, secondary, tertiary prevention, that sometimes that doing it for everyone at the bottom to make this a standard norm is part of the picture. And then thinking about it as treatment from your highest sub. So it's an and, I would say. And to the second part, I'm a home-based primary care physician. And I think the reason why my outcomes are probably good, it's relationships. It's the fact that a year ago, I went on Halloween with my 4-year-old to my patient's house so that she can take her blood pressure in a mermaid outfit. And, what controlled her blood pressure? I don't think it was the medication. I think it was the joy of knowing me and knowing family. And so I think there is a path to get there. I do think it takes all of us with our collective voices speaking forward.
And if I can just say one more thing is that we do hear from our prescribing partners that the ability to prescribe that joy, right? The opportunity to say, I can give you something that is going to be fun and not just like a medication can be really helpful and healing for them and for that relationship, right? And so again, not asking doctors to find every community activity and personalize it to their individual patient, but to even just kind of introduce that idea of like what matters to you, how can we connect you with something important to you that will help you with your health.
One other, sorry, we just love talking about joy, guys. One other comment I was going to make to that is that, there is a one question dignity assessment that I've started using in my new patient encounters that is, what do I need to know about you as a person in order to provide the best care to you possible? And there's data behind that question, not only that it impacts the patient's experience of dignity, but actually that it impacts your experience as the doctor and your connectedness to them. And so that's why I ask it. And I think it's just interesting to wonder whether going back to the point that Carla made in the beginning, whether if we think about this more as, something that art pharmacy's job is to connect, I'm never going to know all of the organizations assist. But if I can invest those 7 minutes in the connection with the patient and in building relational equity, and then at the end of it, I'm like, I'm going to send you to art pharmacy. Like, I don't know what they're going to do, but I think like I now know you and I have a sense of what brings you joy and I see how lonely and isolated you are and I like want to do that. Meet you, maybe it gives you an opportunity to have that like mommy experience.
Thanks. I have a question a little bit more about what a link worker might do. And so if a link worker, I'm curious about how a link worker decides where to send someone, and particularly in the case of when the link worker asks what matters to you, what if their interest isn't available in the community? If they say I really want a group to play D&D with, and there's not that specific thing, what does a link worker do? And it also gets back to what you said earlier, what if they don't want to do the arts?
Yeah. It's a great question. And I'll say at our pharmacy, we try to include virtual experiences for things that might be very niche or specific that people really want to engage in to be able to meet those needs. We have a bunch of that are coming to mind of just stuff that I'd never heard of, but people come wanting to do that kind of stuff. But we also really take a motivational interviewing, health coaching perspective to it to say, it is about the activity, but it's also just about getting you into something that's going to help you feel connected and express yourself, et cetera, what those goals are. And so it is a conversation or a back and forth or an assessment essentially at the beginning of their time with us to be able to get to know them and understand what their goals are and what those barriers might be and coming together with a plan for addressing them. And those barriers can be hard barriers, like I can't afford it, I can't get there, but they can also be those perceived barriers, like this isn't the place for me, or I don't want to do art, or I'm not an arts person. And so it's more about that conversation of let's figure out how to get you connected. And if the genre or type of art is the most important thing, we'll get you into something you want to do. But if you don't necessarily know or you're less aware of what's available out there, we'll help you find it. So it's that's what I'll stop there.
So where the research of where we're trying to understand the gaps. And Dr. Wells and I research, what we're trying to do is understand the process and look at it from the lens of social connection, what we know, the structure, function, quality of relationships, and try to get a better understanding of what someone's gap is and what is it that they actually need. Because current state is physician or healthcare provider sees a person, something Black, they don't know what to do to send a social worker, they send them to something they never go to. And it's probably because we're not doing a good job of assessing and doing the dignity work to figure out what matters to you and what's available. And then the other thing is that our virtual Rolodexes are not complete. And so I may be more likely to just refer to the one organization I know, but as you say, that may not have their one thing that they want. And so that's where we need to go to understand a little bit more so we can do this better.
And that's why, in the UK, they have those link workers, right? They acknowledge that this is, it's almost like a community health worker in our system, or we call them care navigators. It's a specialized role that is dedicated to getting to know that person and helping them navigate these spaces.
I think you'd be surprised. I have been surprised with the things that my patients have said they would never do, that they come back and are like, I went to the ballet. I out of patient, this little lady who went to a hip hop class and said it was one of the coolest things she'd ever done. Or a gentleman whose wife was telling me so much about they went to this sip and paint class and he painted this picture of flowers and hers was better. But he would have never said that he wanted to do that. So I do think there's a lot of motivational interviewing work behind the scenes to get them to do it.
We are at time. I know I want to keep talking and answering questions, but we'll be here for a little bit if you want to come and chat with us. Thank you all so much. Thanks for this panel. Really appreciate everybody. Thank you.